All right, let's just talk briefly about the ear. So the ears are the sensory organs for hearing and maintaining equilibrium and balance. It's broken down into three parts: the external, middle, and inner ear. The external ear can be referred to as the pinna or the auricle, and its opening, the S-shaped opening, is referred to as the external auditory canal. The auricle or the pinna consists of movable cartilage and skin, and its shape serves to funnel sound waves into its opening through the middle ear. The canal is about 2.5 to 3 centimeters long in adults, and it terminates at the eardrum or the tympanic membrane. The canal is also going to be lined with glands that secrete cerubrium or wax, the material that lubricates and not only protects the ear but keeps foreign bodies from entering farther into the ear beyond the tympanic membrane. The external ear, the outer canal, is made of cartilage. The inner 2/3 is bone that's covered by a thin skin, and like we said, it has a slight S-curve shape to it that helps us to funnel the sounds. Lymphatic drainage of the external ears flows to the parotid mastoid and superficial cervical nodes. The eardrum or tympanic membrane separates the external from the middle ear. And when we look at the tympanic membrane, if we can look at it with an otoscope, it should be translucent, kind of shiny with a pearly gray color. And we know, in addition to kind of being that blockage or that separation between the external or the middle ear, it also allows sound waves to produce vibrations on it that is transmitted farther into the inner ear for the production of sound all the way up through the auditory nerve, through our cranial nerve 8. So this is just a couple of the landmarks with the tympanic membrane. The superior portion, the pars flaccida, or the kind of the bottom, the pars tensa. And this is the cone of light where if you actually take an otoscope and look at the tympanic membrane, it's going to give you a reflection back of a light through the cone of light. And the whole entire surrounding, I believe, is referred to as the annulus, and that's the outer rim of the eardrum, or the tympanic membrane. So within the middle ear, we know it's a tiny air-filled cavity inside the temporal bone. It also contains 3 ear bones that are responsible for the production of sound. They're also referred to as ossicles, the malleus, incus, and stapes. In the middle ear, there are several openings. One is through the outer ear that's covered by the tympanic membrane. There are also openings to the inner ear, which is referred to as the oval window at the end of the stapes, and through the eustachian tube, which is the opening that connects the middle ear with the nasopharynx and allows the passage of air, which it maintains equalization of pressure between kind of the middle ear and the inner ear. The functions of the middle ear, obviously it's going to be kind of a canal that functions to conduct sound vibrations from the outer to the inner. It helps to protect the inner ear from too loud of sounds. And like we said, our eustachian tube, or the kind of the drainage tube, allows equalization of air pressure on each side of the tympanic membrane so the membrane does not rupture. So like when we go on flights, we're up in an airplane. So with our inner ear, we know it contains the bony labyrinth, which also is responsible for equilibrium and hearing. The vestibular and the semicircular canals within the bony labyrinth are composed of the vestibular apparatus. And the cochlea contains our central hearing apparatus. We know there are tiny projections of hair that are in the cochlea that help to not only to produce but to transmit sound further along in the inner ear. So subjective information when patients come in with ear pain or atalgia. Is it associated with an infection or a trauma? Or is it possible that we've got a lesion? And if patients come in with ear pain, earache, we're going to look it up from a PQRSTU standpoint. We're going to get very in-depth, comprehensive. Infections. Do they have a current infection? Do they have a frequent history of childhood ear infections, otitis media, otitis externa? If the patient has discharge, is it clear, or is it purulent, or is it bloody? Sometimes we patients who have got skull fractures, they may have otorrhea, which is leakage of cerebral spinal fluid through the fractured cranium and the dura. If it's a discharge that's yellow, kind of thickened, we might think otitis externa or even media. Hearing loss. Is it sudden in onset, which is a problem? We might speculate a lesion, a tumor. Is it a gradual progressive hearing loss with somebody who has presbycusis? Is it related to environmental noise, things that they're doing with their job? Do they work construction around loud noises all day long? Is it some of the hobbies that they participate in? Concerts? Is it the music they listen to through their headsets, their earphones? Tinnitus, we always associate with kind of ringing in the ears. Tinnitus can sometimes be an early precursor to hearing loss. So in somebody who's got a neural or sensorineural hearing loss, it could be tinnitus. This could be what started. So that sensation that you hear things ringing. On vertigo, we know it's that sensation that the room is spinning, or you've got kind of this whirling sensation where you feel like the things around you are moving or you're moving. And so vertigo, you think, is it associated with hearing loss? Is it associated with ear aches, headaches? Some of those patients could have Meniere's, or they could have a positional vertigo. Or is it related to a lesion, a brain tumor? And so self-care behaviors. When was the last time that you had a full comprehensive exam where they checked your hearing? Or have you recently had your hearing checked by an audiologist? How about cleaning your ears? What kinds of methods do you use to clean your ears? Are you somebody that's putting objects down your ears where you're not supposed to? So objective ear assessment, the inspection. So are our ears, the size and the shape, are they symmetrical from right to left? Are they too small or are they too large? There are terms for that, microtia and macrotia. When we're looking at the skin condition, is it pretty much consistent in color to the rest of the body? Is it intact, or do we have some crustaceans or scales, or maybe linear ridges or ulcerations? Is there any redness on the pinna or the auricle or even the tragus? Is the redness associated with discomfort or pain when those areas are kind of palpated or pushed? Is there any swelling of the ear canal, or even behind the ear around the mastoid process? Sometimes this could be an indication of mastoiditis. And like we said, looking at the discharge, is it yellow purulent or is it clear? And a lot of times your patients who truly have a cerebral spinal fluid leak from skull fracture, cerebral spinal fluid has a high glucose content. And so actually if we put it on like a gauze pad, it will coagulate, like it will become kind of ruddy in the center, but it will have kind of a very clear, translucent, kind of yellow colored surrounding the blood in the center. Does it have an odor? Does the discharge have an odor? The presence of cerumen or the earwax, is it dry? Is it kind of wet? Does it look impacted? Does the patient have a history of impacted earwax cerebrum as well? And we talked about symmetry, looking from right to left. And where is our ears in placement to our eyes? So we know that the lateral canthus should be somewhat directly in line with the top of the ear, the top of the auricle. And so when it's not, when there's a greater angle between the lateral canthus and the top of the ear, we refer to these patients as having low set ears, and it can be associated with some genetic defects, genetic conditions like Down syndrome. Right. So this is a picture of impacted cerebrum. cerumen, like earwax. So some of our older patients, when some of the earwax becomes a little bit more drier, they're more at increased risk for having impacted cerumen, which can alter air conduction and hearing. Okay, so usually it has to be pretty obstructed in order for hearing loss to be affected by earwax impaction. So these patients, sometimes we can use the medication drops to actually dissolve and remove the earwax, or sometimes they're actually going to have instruments to have to go down and remove these. I also might think to ask these patients, are you putting Q-tips or objects way too far down in your ear where you shouldn't be? This picture right here is acute otitis media. We know this is an infection, inflammation of the inner ear. It's an acute infection. A lot of them can be viral in nature. They don't always have to be bacterial. But usually the tympanic membrane is going to be pearly gray and kind of translucent, and there's going to be a reflective light on it. Acute otitis media, their eardrum is kind of red. It's not as shiny as it once was, and it can actually be kind of bulging. So these patients are typically going to need antibiotics. There's not really a whole lot of evidence to support doing culture of drainage. So if these patients present with ear pain, a throbbing ear pain, a little bit of fever, refer to headache from the ear pain, most often they're going to put them on antibiotics. Okay. Now, unless they have recurrent ear infections, chronic ear infections, then they might consider doing a culture or eventually doing PE tubes on these patients. Otitis externa, so this is going to be an infection of the external ear. So this can be also referred to as swimmer's ear. It also can be related to like a scratch or an irritation on the external portion of the middle ear, or the outside of the middle ear. So these patients, usually the ear canal becomes very swollen, they have drainage, and it's very uncomfortable on the outside of the ear and the ear canal. And so most often these patients are going to need like antibiotic drops or ointment. This is a picture of somebody who has a perforated tympanic membrane. It can be very much associated with acute otitis media. When it becomes so inflamed and enlarged and bulges, it can actually perforate. So these patients, usually they'll have intense pain, and once it perforates, sometimes the pain goes away, but they'll have drainage with it. So otomycosis, so patients who have an infection of the inner ear related to a fungus. And this is not common. It's usually found in patients who have immunocompromised systems, maybe patients who have been swimming or have gotten some lake water that's contaminated in their ears. Maybe, I think patients in maybe warmer climates. And these patients are going to need antifungals. This is a picture of a PE tube. It's inserted right through the eardrum of the tympanic membrane and helps to kind of equalize the pressure, and also it helps to drain some of the fluid in these patients who have got chronic ear infections. Most commonly our patients who have chronic ear infections are children, because their eustachian tubes are not very steep like they are in adults, so they have a difficult time draining. So some of our patients who have got frequent ear infections and they've got chronic fluid that has accumulated within the middle ear, they might have to put tubes in to allow it to drain. So these have a lifespan typically about 18 months to 2 years, and they'll eventually fall out. So this is a hemotympanium, or kind of a bloody eardrum. So some of these patients can actually collect blood behind the eardrum if they've had head trauma, skull fracture. So they can have bleeding behind the eardrum, and it looks blue behind it. So carcinoma of the ear. So while these patients are going to have some sort of lesion that's somewhat crusted, scaling, and it's going to be difficult to heal. It's not going to heal. It's going to bleed very easy, and it's going to commonly be in an area that's exposed to the sun frequently. So in addition to the inspection, like we said, we're going to palpate along the auricles, the pinna, and the mastoid areas, the tragus, and look for any tenderness, swelling, or nodules associated with redness. When we talk about doing hearing assessments, we know the most easiest one is kind of the whispered test, the whispered voice test. We know that we're going to usually stand about 1 to 2 feet away from a patient's canal, and we're going to whisper usually 1 to 2 syllable words, or 2 syllable words, maybe a couple of them, and see if the patient can hear us. We're going to ask the patient on the opposite side to actually take their tragus and move it in and out of the opposite auditory meatus that we're speaking into. It kind of helps block out some of that background noise. We don't want to hear it on the other side. We want to make sure that we're doing it in the right side. So we know the Weber test, we're going to be using a tuning fork. This is going to be checking for bone conduction. Okay? And so we're going to tap it and put it right on the top of their skull, top of their head. Patients who do not have hearing loss or problems with conduction, they should be able to hear it equally in both sides. If it lateralizes or localizes more in one side, then we might speculate that they have hearing loss in the one where it's not as intense. So when we're doing the RIN test, we know we're checking the difference between bone and air conduction. So typically in a RIN test, we should always have air conduction that is more than bone conduction. So when we hit the tuning fork and we put it behind the mastoid process, we're going to leave it there until the patient stops hearing the tone, and then we're going to quickly invert it and put it to the side of the ear so that they can check for air conduction. They should always be able to hear air conduction longer than bone conduction, okay? And that's positive RIN, that's positive, that's where we want to see it. And if it's not, if it's the opposite, these patients could have hearing loss, they could have problems with conduction, loss of air conduction. And so they're going to probably need to be referred for more in-depth testing to an audiologist. So some of the things to consider with aging adults, what are the normal variations? So the ciliary lining within the ear canal can become coarse and stiff. This causes some problems with the accumulation of wax, okay? Which can, if it becomes too dry and it becomes impacted, it can reduce hearing. Some other things, patients who are older at increased risk for presbycusis, which we know is hearing loss that's related to the aging process. So they actually have degeneration of the nerve in the inner ear, or the auditory nerve. It's a very slow progressive hearing loss. Patients usually have a hard time hearing higher frequency tones, not able to localize sounds as well, and they also have a difficult time hearing with background noise. Sometimes we actually start to see coarse, wiry hairs starting to grow out of the patient's ears. And due to the loss of elasticity within the tissues, these patients are going to have a lot more wrinkling. Their earlobes are going to become a little bit more pendulous and looping down. So some of the things to consider with cultural and genetic considerations, like we said, otitis media, a lot of your younger children are at more increased risk for otitis media because their eustachian tubes are not as steep and they don't drain as well as like the older adults. They do find that not only children, but also children who are bottle fed and they're laid flat for periods while they're being fed are more at risk. And I think it's a little bit socioeconomic as well. There are factors that play into that increase their risk for ear infections, otitis media. And so earwax is genetically determined, and it comes in two types, dry or wet. Asians and American Indians typically have a higher frequency of dry earwax, and African Americans and whites have a higher frequency of wet earwax. So it's genetically determined. So we need to make sure that we realize that it's genetically determined, that it's not necessarily related to poor hygiene. And we also need to make sure that when we're looking in the inner canal, if we can, to avoid mistaking flaky, dry earwax for any type of eczema or enzymatic lesions.